So let's just look at the sort of thing we're talking about. This is one of my aunties. This is auntie very quickly. She's got diabetes. She doesn't look after her health very well. She keeps falling over. Her daughter is sick of her falling over. Takes her to see the GP. Some lab tests are done. They go back to see the GP. They get off to see a physician. That takes 3 months. She falls over twice and ends up in hospital. She gets off to the pharmacy. She gets off the district health nurse, and she has her insulin changed. This whole process in changing auntie's insulin took 14 weeks. There were 6 provider contacts, 3 days off work for the daughter, and 2 hospital admissions. There's not much to recommend that care. Alternatively, the district health nurse could have tested auntie, uploaded it onto auntie's health Facebook page, flicked it off to the family doctor electronically, who uses that password auntie gave them to have a look, sends it by phone to the physician who says change the insulin, and the pharmacist does so. That's 1 hour, 1 provider contact, no days off work, and no hospitalisations. Well, let's get rid of some of those people. The physician and the GP can be there in an advisory capacity. Why don't we just have a direct communication with the district health nurse and advanced care pharmacist? Well, let's do even faster still. Let's just train a nurse to become a diabetes nurse prescriber. So what's holding us back? What's holding us back from the current provider-centred approach to this patient-centred approach? Well, the mobile test units exist. We can do that for 50 or 60 cents a test. We need a shared care record. Is Graham Osborne here? When you see Graham Osborne, those of you, tell him that 2014 is an unacceptable time for a shared care record. In a world of Facebook and electronic internet banking, you telling me we can't have a shared care record. Shared care records are the single most important enabling technology we need for almost all of the innovations we want to do. When you see him, Jeff, have a word with him. The other thing we need is a reward system. One of the reasons why we have fragmented care is we have fees for service which require discernible transactions. You will not get seamless care or virtual health care in a transactionally funded world. Now, this is not to argue the current GP capitation makes sense to me, because it certainly doesn't. When you get money to have people on your books, but it costs you money every time they come to see you, you have a pretty dumb capitation in terms of driving care to areas of need. And it's how we get the incentives up to an organisational level and an outcome level. For example, by the way, there are still, in the procedural realm, paying for procedures still makes sense. I'm not arguing this is a uniform thing. But if, for example, if I said to you, we'll pay you for your diabetics against the prevalence of diabetics and renal failure and those that go to hospital, I'll say, look, we'll fund your system, but we want to keep your diabetics out of hospital and out of renal failure. That would generate the sorts of intercollegial behaviours we want. If we said, we're no longer going to fund you to deliver babies, we'll fund you as a group to have healthy mothers and healthier babies, I'd suggest you get profoundly different referral practices and engagements and collegial behaviour. If you get that up to the level of an organisation, don't fund it at an individual level for procedures per se, because that often involves widget chasing and competitive behaviours. But getting these capitations right is an important part of how we shift from that form of care to this form of care. And the final bit, the bit that I don't know, the bit that we don't have a lot of intelligence about, and the bit that I'd ask you to think about is, how do I get auntie to take some responsibility? How do I get auntie to get some skin in this game? Because the person least committed to this process, quite frankly, was my auntie. She was a passive recipient. So how do we get auntie to get some skin in this game? Just quickly, the affordability issue, I'll just show you one graph here. If you remember nothing else than what I said to you today, this is a lifetime for some of us, 1950 to 2010. This line here is the growth in GDP of our country over that time, 133%. The red line is the growth in health costs over the same period, 417%. You do not need to be a Harvard economist to look at that graph and realise the divergence of the red line from the blue line is not good. It's an extraordinary mismatch between affordability and cost. And you'll see that the national government, tutoring the market forces, didn't exactly do much, and this is the period of DHBs, primary health care strategies and so on. Loss of productivity at a time of incredibly accelerated costs. What a pity that the policymakers here and here didn't spend more time talking to clinicians. This, though, this mismatch shows that not only do we have a demand-supply mismatch, we have a demand-supply affordability mismatch. If we peg health costs to GDP, then you end up with a neat 100% growth in demand, 40% growth in workforce, 40% growth in funding. There's your conundrum. 100, 40, 40. How do you match 100 to 40 to 40? The answer is by doing things differently. This is the thing I'll finish on. I'm sorry, Martin, I'll be 2 minutes. It is a truism in health workforce planning that will inevitably get it wrong. Actually, the observation is no one's ever got it right. Ever. No one has ever got health workforce planning right. The other day, the Director General said to me, do we have a nursing 2020 plan? I said to him, when was the last time you saw a sensible future health workforce plan for nursing? He said, I've never seen one. I said, well, why are you asking me for one? It's ridiculous. It's like the doctor of 2020. Well, go ahead and write it if you like. But I'd suggest all you're doing is... Anyway, it doesn't matter what I think you're doing. When we were medical students, Bruce, you and I, we would go along to theatre, we'd hold a retractor for someone doing peptic ulcer surgery. Did you ever think that someone would discover a bug which was the cause of peptic ulcer and just abolish a whole area of need? When I started my PhD in Sydney in 1980, the professor of neurology took me aside and said, these are the 3 things you need to know, son, besides calling me sir. One is you're born of a certain number of brain cells. The second is that what you do doesn't change brain morphology. And the third is that you're born with a certain number of brain cells. What you do doesn't change brain morphology. Oh, and your brain's hardwired. Completely wrong, and completely wrong in my lifetime. The entire basis of neuroscience tossed out the window in my lifetime. If you go back to 2001, how many of you would have predicted in 2001 the circumstances of today? I'd suggest none of you would have. So why would we arrogantly assume we can predict the future? So what does this mean? This means we can either give up and resort to serendipity and rely on the vagaries of the marketplace, or we can adopt principles that enable planning. And that's what I want to finish on today. These are the 3 planning principles that we are trying to use at Health Workforce New Zealand to account for this intrinsic uncertainty. The first is that our intelligence must be dynamic. If the goalposts are shifting, we need to know where they are. The second is that most of the health workforce needs to be able to be flexibly employed and quickly retrained and redeployed. The argument here is you have fewer physios and OTs and speech-language therapists, and those that you have act as consultants. But what you have is a generic rehabilitation worker who can do physio and OT and speech-language therapy. Last year, as you know, in Auckland, with the change in ACC funding of physiotherapy, thanks Kevin, a lot of physiotherapist graduates could not find a job. The point is not that. The point is that, in fact, they either had to go back and train all over again or go to Australia. The portability of their training, the ability to retrain, was so limited that it was start again or go somewhere else. Whereas someone generically trained as a rehabilitation worker can be the rehabilitation service at Whakatane Hospital, or they can be in stroke rehab or Tauranga, or they can be involved in speech-language recovery programs at Auckland City Hospital. But the point is, as needs change, they can be very quickly redeployed. And the third principle is this: if you have a slow-to-train and expensive health worker, and doctors are the prime case of that, if it takes 15 years and $1 million to train a doctor to vocational independence, that 15-year period is a time of extraordinary uncertainty in demand. So, in fact, surely to make them as less vulnerable as possible to disruption, they should be kept in as general a scope of practice as is possible for as long as is possible, because that's the only way you can protect them against disruptions of need. The second thing is that surely if we're going to spend 15 years and $1 million training someone, they should be working at the top end of their licence. In other words, doing things that only they can do on the basis of their education, training and experience. Surely we have to people like that working at the top end of their licence. I'll quickly skip over this. This basically is a graph you've seen before. These economic data show that not only is generalism an argument which has substance in protecting against uncertainty, but if you look at the number of GPs versus quality, or the number of GPs against cost, in any particular, this is Medicare, which consumes about 9% of GDP in America, so it's a huge health system. As you drive the number of GPs up, you drive quality up and costs down. Conversely, if you look at the number of specialists in the community against quality, quality goes down and costs go up. There are fiscal and outcome arguments for generalism as well. This is not an argument against specialisation, but it is an argument for specialisation as well as, not instead of, generalism. So, to summary then, an affordable, sustainable and fit-for-purpose health system can only be achieved by way of a clinician-led, and one of the things we're going to have to invest in is teaching clinicians how to lead. That means contextual leadership, that means values-based leadership, and that means learning how to become a constructive follower, which is not necessarily easy for many of my profession. Intelligence, informed, and you now know what I mean by intelligence. Innovative reform of funding and remuneration. I do not believe that the reforms in plumbing that have gone on within the ministry will get us from 8% growth per annum to 3%. It's going to require a whole lot more than just that. And a reform of service configurations and models of care, and I put the health and disability sector, and if we've got problems doing this in the health sector, doing it in the disability sector, makes the problems pale into insignificance. Given the intrinsic uncertainty, the only thing that's certain about health workforce is that it's profoundly uncertain. Health workforce planning, and by the way, if you want an illustration of how badly we've been health workforce planning, just go back and read newspapers the last 2 decades and just follow the cycle of nurse excesses and deficiencies, shortages, crises, unemployed nurses, shortages of nurses. Just follow the cycle, and you get some idea of how ad hoc this planning has been. Well, little surprise. So anyway, health workforce planning must be informed by dynamic inclusive intelligence, needs to create and maintain a core workforce that can be employed flexibly and redeployed quickly. That's our direction of travel. And we must ensure that those necessary elements of the workforce that are slow and expensive to train have a scope of practice that is as general as is possible, and the footnote, and are employed at the top end of their licence. So I would suggest to you that our health system does extremely well in 2011 due to the quality of our health workforce, but I do not believe that our current health system is either sustainable or fit for future purpose. We have a terrible, liberating conundrum of 100% demand growth with probable 40% workforce and 40% funding growth, and that conundrum is terrible but liberating. It liberates us from the status quo. We share that problem with the rest of the planet, and we're going to inherit some problems with the rest of the planet. Last year, India signalled that it's going to go from being an exporter of doctors to being an importer of doctors. For the first time ever, India is going to allow foreign doctors to register in India. Can you imagine the effect on the global workforce when India stops propping up all the other workforces around the planet? Can you imagine? And that's, by the way, as a direct result of the growth of the middle class in India and the consumption of healthcare in India by the Indian middle classes. And the health workforce for the 21st century has to be far more sensibly and flexibly arranged, deployed and available than the rigid, siloed health workforce we have in 2011, because that's what renders us not fit for future purpose. And thank you very much, Armin.